Hello, and welcome to the second module update in the effective management of patients with lung tumors in the COVID-19 era. Today's session is approved for 0.25 hours of CME, CNE, CPE, and AAPA credit. This series is provided by the North American Center for Continuing Medical Education, an HMP company, and is supported by educational grants from Merck and from Pfizer. My name is Corey Langer, and I'll be the moderator of today's program. I'm the Director of Thoracic Oncology at the Abramson Cancer Center and Professor of Medicine at the Perelman School of Medicine, University of Pennsylvania in Philadelphia. And I am honored and pleased to be joined today by Dr. Roy Herbst, the Ensign Professor of Medicine and Medical Oncology and Professor of Pharmacology at Yale, Chief of MedOnc at the Yale Cancer Center and the Smilow Cancer Hospital, and Associate Cancer Center Director for Translational Research at Yale in New Haven, Connecticut. We're going to take the next 10 to 15 minutes to discuss the evolving standards of care in thoracic oncology in the hope of avoiding any compromise to clinical outcomes, and also a very close look at how we manage clinical research in this new era that we've suddenly and inextricably entered. So, Roy, if you can weigh in.
Oh, excellent. So, well, it's been a challenging time. Ironically, I think lung cancer therapy and research had never been better. You and I have been doing this, Corey, 25, maybe more
30
years. And, look at the last 10 years with targeted therapies, moving them to the earliest stages of disease, the immunotherapy revolution. Just in the last month, there have been several approvals, of Medexon 14, RET. So, we really had our full armamentarium. We had a whole bunch of clinical trials, whether they be industry, NCI, consortium trials, and then just boom, everything just came to a halt. And it really, we had about a month to sort of get ready. I know at Yale, we had a retreat. I think it was March 5th or 6th, and we discussed what would we do if the virus came. And then, a week or two later, everyone was working from home. The clinics were pretty empty. As a clinician, of course, I still came in and saw patients, but, patients stopped coming in. People didn't want to come in, or they came in wearing double gloves and masks and so forth. And, that's where we are right now. But the lung cancer, the people that were being treated have to continue to be treated. And for them, we've managed them with telemedicine for visits that didn't require an infusion. And then we've made the infusion centers safe. I think the key thing has been to keep our centers safe for our patients and our staff. And, the masks, early on, no one knew what masks to use. Now everyone has a mask, usually regular surgical masks. We have N95 respirators, when we know that someone's positive. We started to screen. That was slow. Our hospital developed its own test. We started doing some of the rapid tests. Now we can test someone with a 2-hour test when they come to the emergency cancer clinic, so we know if they're positive. And, we're treating people not so much on protocols. If they've been on a protocol, we've kept it going. We started doing remote monitoring. Yale never did remote monitoring on protocols, and now that's beginning, so that because we can't have the monitors in for the protocols. And then for therapy, we're doing the best we can. We're spacing things out. If we can avoid a 3-week visit, we're giving pembrolizumab every 6 weeks. If we can avoid chemotherapy, we're using immunotherapy alone. If you can use a targeted agent, like an EGFR inhibitor, we use that. And I was just in clinic the other day, and I felt pretty good. I didn't see many patients during this period, but I have a few where I really think that we've helped them. People that came in quite symptomatic who had EGFR disease, we were able to still diagnose that. They're feeling well, but a few immunotherapy responses. So we're plugging away. Patients are very grateful. But I still remember one visit where I was seeing a patient who was a 1% PD-L1 patient. Would have probably put them on chemotherapy, immunotherapy, but we avoided the chemotherapy. I'm explaining that to him. We started him on the immunotherapy. He actually had a mixed response. I had to tell him that, we needed to change, and we decided to go with the chemotherapy. His wife's calling from the car because they don't even let the family in. So
it's hard. It's very hard.
But just saw the fellow the other day, and he responded, and we're getting people through. I think the one thing I'm beginning to realize, and now as the chief of the oncology group, I'm trying to get the staff to realize, is we can work. We're going to have to work. This is the new normal. It's going to be with us for quite some time, and we just have to be as careful as we can, but continue to treat lung cancer. And then I really am glad that the pulmonologists are getting back to work. They're screening all their patients first with a COVID test 48 hours before. The surgeons are getting back to work, and that means we'll have more cases. And again, the cases are not going to go anywhere. We know that there's lung cancer is the most common cause of cancer death, and second most prevalent cancer in men and women. So we're going to be busy, and we'll figure it out.
It seems like those patients who are going on TKIs uniquely lend themselves to telemedicine. They can get their scans done locally. The disc can be sent in. They can avoid coming to the hospital center. The only thing we can't do in telehealth is do a physical examination, but pretty much everything else can be accomplished. And of course, the medication can be sent to their homes without their necessarily coming to the clinic. But you mentioned both immunotherapy and chemo. Are you taking special measures to avoid neutropenia, giving growth factor more commonly? For those who are getting chemo and immuno, are you stretching out the intervals to 4 weeks instead of 3? How are you adapting there?
Well, two things. The telehealth is amazing, and I love doing that. I actually have a New Jersey license now, Corey, because I've done some telehealth with New Jersey patients. I got an emergent. I'm getting closer to you, and but it's a challenge. Not everyone can do the video telehealth. We've done a lot of phone visits. It's not the same, and certainly you can miss things. Subtle skin findings, and sometimes it is good to listen to the lungs or get an X-ray. But it is a way to stay in touch, and I think we'll make that part of our care. But we're trying to space things out. So you have to, so if someone's getting maintenance therapy, let's say with pemetrexed and pembrolizumab, we might drop the pemetrexed if it's been, a long period of time. If the patient's on a protocol, the sponsor doesn't always love that, but we've done a little bit of that. If someone's getting chemotherapy, we might try to space out the interval. I agree, using growth factor. You don't want people to be neutropenic. The terrible group showed us that neutropenia and the group is clearly a risk factor for poor outcome if you have the virus. Makes sense. So we have to realize that our patients will be exposed. Though quite frankly, most of them are staying at home and aren't going out. And I've had a few cancer patients in New York who have been a little pressured to go to parties every once in a while, and they say, "We have taken my mask off, Dr. Herbst." I said, "Well, I wouldn't do that." I think people are getting a little bit more willing to do that, but I think if you have cancer,
I think there's some people are very tired of sheltering in place, and so some are starting to get a bit blasé, and now's the time where I think they really do need to continue to enact greater precautions. Before we finish up, I just want to ask how you're adapting clinical trials, what lessons we've learned, and how do we go forward to resume or re-implement studies that were suspended?
Well, clinical trials, take a village, and social distancing or physical distancing, however you want to call it, doesn't work well when you are already in a smaller space and you need to have your data managers and your nurses or your clinical research associates, as we call them, to put people on study. We're doing more and more by video the day before, which is great. It makes the whole clinic flow better, but still it's hard to do that. We stopped all of our clinical trials. I actually supported that because we had at one time 450 patients in our hospital. We weren't sure we'd have enough ICU beds. The ICU at Yale holds 35, 40 patients. We had 120, 130 ICU beds. Our cancer floors are now ICUs. And fortunately, it's come down. So from the peak of 450 patients in-house, I think we have 35 today. So it's a lot better. But how can we focus on protocols when that's going on? And it's a shame because now we're in an era where we're targeting RAS and RET, and there's really no therapy for these patients in lung cancer besides these trials or these drugs. So we're getting those back. It's hard to get everything back to you have a lot of inertia, and starting to get moving again has been hard, but we are. We have to get some of the specimen people back because
Right.
all these trials have biopsies. Take it for granted, but someone's got to pick it up, run it over, send it out. So where you need the labs to be open to do that. So the labs now have half as many people. People are working in shifts, but that's happening. Then we're opening up a couple of trials per disease team, and it forces you to be a little bit selective. You realize, I think we had probably 400 or 500 trials going, and a couple hundred investigators. You probably have the same thing, and you probably don't need that many.
No.
And I actually believe, in having a balanced portfolio. And I think much like you, have a good nose for what's good and not, and take a little balance of industry trials and investigator-initiated trials, and always keeping something going. But we're beginning to get a few things up and running. One of the things we had been doing at Yale quite well is we had taken our cancer care outside of the city, and we went to 13 care centers as far south as Greenwich, as far north as Westerly, Rhode Island, believe it or not. So we were running trials there, so we have to get the trials going at those places. So, we haven't had to lay anyone off. The whole team's been working. Tried to use this time to get the data in better shape, to think about new ideas, continuing to meet with people, keep the morale up. But it really did grind things to a halt. And clinical trials make cancer care better, as you know, because one, if you're thinking about a trial, that means you're thinking about the standard of care. So you're really treating the patient in a better way. But two, the trials that we're doing now, or we were doing 5 years ago, are all standard of care. Both of our centers were doing immunotherapy trials, the targeted therapy trials, and not having that is a big issue. Pat LaRusso at Yale had a big phase 1 effort going. That stopped. And phase 1 was about a third lung cancer patients. I'm sure it's the same, most places, lung and GI. So it's I want to try to get the best therapy for the patients. We did have a few people who had been set for TIL therapy. So as you know, TIL therapy, is months in the planning. They've had the surgery, the cells are ready. We were able to get those patients through. We had a few ethics consults, but actually there's one patient, a melanoma patient, who's doing great. So we have to advocate for our patients, but we also have to be careful. We don't want to put someone in a situation where they might need an ICU bed and there are none. And the medical team was quite taxed. We started a trial. I took some of my research team. We started collecting specimens, patients with COVID who have cancer and lung cancer. We're collecting their blood, sputum, stool, and we're trying to get a sense for what's happening. What antibodies are they making against the virus? How does that affect the cancer? In some ways, some of the antibody responses, the inflammation they're getting in the lung might actually be good for treating cancer. But then again, as we all know, those patients, when they get that fibrosis and those infiltrates in the lung, they don't do very well, and it takes a long while to clear. So it's a bit of a mixed bag. But we're a big hospital. We're a community hospital, as well as a teaching hospital and an academic center. So, 1,500 beds at Yale New Haven. So we can't just take the cancer and isolate it. We have to be we're part of the whole group, as opposed to some freestanding centers. But we've gotten through it. I think the team's worked well. We meet more than we ever have. I know everyone in the organization. There are a lot of people who I didn't really know that well, but you see their Zoom and their picture. In fact, it's almost too many Zooms. I don't know how you feel about this, but it's all of
I
a sudden
too am a bit zoomed out, but I think it's the necessary consequence of what we're dealing with. I think also the accelerated approvals of many of the medicines, the new agents that you and I have both been investigating, have helped both take the pressure off research and certainly help the patients. And I think we've also learned, I'm sure you've seen this, that many of our visits on clinical trials are really quite gratuitous, that they're not necessary for either the integrity of the trial or for establishing the safety of the drug, that much of this can be accomplished through phone calls or video camera, and that I think it will ultimately lead to a relook at how we conduct trials and how we can streamline them.
Well, I agree. We need fewer blood tests. We need fewer EKGs. We need to make these more patient friendly and minimize work because it's patient time, it's medical staff time. So I think we're going to see much more of that, more user friendly type trials.
I certainly hope so. So thank you for joining us for the program today. If you have any questions, please submit them in the Submit a Question tab located in the right-hand navigation bar. One of our expert faculty will respond to your query. To receive your CE credit for today's program, please complete the evaluation located in the right-hand navigation bar. You will then be able to download or print your certificate. And please join us next week when we launch the GI Solid Tumor Expert Roundtable. Thank you again for joining, and thank you, Roy, for spearheading this effort. It's been great talking to you.
My pleasure, Corey. Thank you.